I'm Gregory Lip. I'm Professor of Cardiovascular Medicine at the University of Liverpool. I'm Director of the Liverpool Centre for Cardiovascular Science at the University of Liverpool, Liverpool John Moores University, and Liverpool Heart and Chest Hospital and other NHS partners in the UK. I'm a clinical cardiologist, so I enjoy looking after patients. I want to have the possibility to improve clinical care for our patients with atrial fibrillation and atrial fibrillation-related complications, the most devastating of which is stroke. Patients with atrial fibrillation are very common. They're very often elderly. They have multiple risk factors and comorbidities, therefore multimorbidity, and they are high risk of atrial fibrillation-related complications such as stroke, dementia, heart failure, and recurrent hospitalizations. I think it's very important that we can understand the reasons patients develop atrial fibrillation and atrial fibrillation-related complications, that is including risk prediction as well as prevention. When they develop atrial fibrillation, optimization of strategies. If there's atrial fibrillation-related complications such as stroke, how to manage those patients optimally, and post-stroke rehabilitation. All those elements are within the TARGET program, and with the TARGET Consortia program, various similarly enthusiastic colleagues are undertaking research on all those pillars of management, from pre-atrial fibrillation and stroke, peri-atrial fibrillation and stroke, and post-stroke with regard to their care and management. Now, these patient data-driven evidence will be used in novel approaches such as virtual twins to create models how we can identify the patients at highest risk, develop management strategies, and also to be used in prediction of those at risk and those in terms of responsiveness to treatment. I like to see in the next decade the possibility that we have an understanding of why many patients are predisposed to developing this common cardiac rhythm problem. Atrial fibrillation in adults in their lifetime have a 1 in 3 lifetime risk of developing atrial fibrillation, and with the general population becoming older, and therefore with that at higher risk of developing atrial fibrillation, it's important we have the strategies to manage these patients. We have moved substantially forward from the old paradigm of simply giving anticoagulation for patients with atrial fibrillation and forgetting about everything else. And we do know that despite anticoagulation, there remains a residual risk in patients with atrial fibrillation of major cardiovascular events. Hence, this move in recent years towards a more holistic or integrated care approach to managing atrial fibrillation, and that's encompassed within the evidence-based atrial fibrillation better care, or ABC pathway. This has been in guidelines globally. There have been variants of the acronym, such as SOS in the American guidelines or AF Care in the recent European guidelines, and these acronyms are untested without a trial evidence to back it up, as opposed to the ABC pathway, which is proven in 2 independent randomized trials to date. That's the MAFA trial and the Miracle trial, to be associated with better outcomes. And these are in different healthcare settings. And that's also an ongoing randomized trial in Europe called the AFFIRMO trial as part of another Horizon Europe project, which is testing the ABC pathway. So evidence-based, not eminence-based. And having this integrated care pathway and implementation in these patients with atrial fibrillation can reduce the mortality and morbidity associated with this common cardiac rhythm problem.